You're listening to Working in Oncology, a podcast and video show that spotlights oncology practice staff and industry influencers who work behind the scenes to shape the future of oncology. The more knowledge the oncology community shares with each other, the more we all grow. Let's get into the show.
Welcome to Working in Oncology. I am your co-host today, Alicia Evans, and I'm joined by Dr. David Aboulafia.
Hi, Alicia. Nice to meet you.
Dr. Aboulafia, welcome to the show. I've been really looking forward to our conversation. So I've been following your blog, and I think that you provide so many valuable updates on COVID. And I'm eager to hear your insights on how the pandemic has affected you and your oncology practice and your charitable works. But before we jump into the conversation, can you tell our listeners and viewers a little bit about you, your background, and what you do?
Yeah, my pleasure, Alicia. I'm a hematologist oncologist up in Seattle, and I've been in practice for about 30 years now. And my practice is a little bit unique. It's a hybrid in so much as about half the patients I see have HIV or AIDS and are living with HIV. So I've had a long background with viral infections, immunosuppression, and of course the other half of my clinic is devoted to cancer care. And those are focused mostly on people with hematologic malignancies, so myeloma, lymphoma, leukemias, and the like. And so it's kind of a hybrid. And for the HIV folks, I do primary and subspecialty care. And for a lot of our cancer patients, we end up being their primary providers too. But my initial work when I was a fellow at UCLA was in viral infections. So a virus which was the original thought to be virus of HIV was a virus called HTLV1. And that was originally thought to be the virus that causes immunosuppression. And it was subsequently learned that no, we had a different virus, the HIV virus. But my research was in both HTLV1 and HIV. And so I've had a long interest in immunosuppression, viral infections, and of course, cancer care and how the treatments we give can further immunosuppress patients and the consequences of that.
Wow, that's really interesting. But if we could take a little step back, what initially motivated you to become a doctor?
My father was a vascular surgeon, and when we were kids, my brother and I would, believe it or not, we would scrub into cases with my dad. We would just be watching, but we had a kind of an early introduction, really, when we were probably 5, 6, 7, 8 years old.
Oh, wow.
And so I think that connection to medicine was really begun when we were kids, and we later used to work in his office, and we would go down rounds with him. So I think it was kind of a natural extension of that. That said, if I had any athletic prowess, I would not have gone into medicine. I would have been a third baseman for the Detroit Tigers.
So I guess some doctors are made. It sounds like you, Dr. Aboulafia, were born a doctor, born a physician.
Yeah, the name Aboulafia means father of good health.
Really?
Yes, I'm Sephardic, which means Jews from Spain. And so I think it's kind of a family legacy. There are a lot of us who are physicians.
Wow. It was your destiny.
Exactly.
Kismet. So you mentioned that your early work centered around HIV/AIDS treatment, and then you transitioned, it sounds like, more to hematology oncology.
Well, it was, we're back in the 1990s, UCLA was a big hub for HIV research. And so fully 50% of people living with HIV or with advanced AIDS were destined to develop cancers in those days. So probably about 30% developed Kaposi sarcoma, an unusual skin cancer. Another 20% developed lymphomas. And so it was kind of a natural back in those days for hem-onc physicians to take primary care or primary responsibility for those who had HIV and cancer. And it was really only when antiretrovirals became available and therapeutic that infectious disease physicians kind of took up the mantle and started caring for them in vigor. But so many of those patients were sick and debilitated. Often they would move to hospice, and it was the hemonc docs who had the most experience with it. So it was kind of a natural subset of what I was doing as a fellow and later as an attending.
Ah, okay. That makes so much sense. And that's a lot of, I didn't realize that about the history of HIV/AIDS treatment. Towards the beginning of the pandemic, you started a blog, COVID Cogitations.
Cogitations, yes.
I said it. I have problems. Can you repeat it, please?
Yeah, COVID Cogitations.
Cogitations. I apologize. COVID Cogitations. So I wanted to get an idea of what motivated you to start the blog, and like what were your goals? What message did you want to send with that?
Yeah, I think originally I was incredibly frustrated with the level of misinformation that was going on. And in so many ways, it was reminiscent of the early era of HIV infection too. How was the virus spread? Who was affected? What were the prejudices that were coming out in really full force? And it was just so reminiscent on a superficial level. Now, it turns out that there are a lot of differences between them, but in that early phase when it was being referred to as the China virus, and there were a lot of other negative stereotypes going on with it, it was very reminiscent of what people living with HIV were going through in their day too. And so it's hard to imagine now, but when HIV became a thing back in the late 80s and early 90s, Ronald Reagan refused to use that word AIDS in any public address. And there was a lot of paranoia also about how did people get HIV? Where did it come from? How would people who were straight or didn't have unprotected sex might get it? And that kind of level of misinformation and the paranoia that was going on struck me as very similar, or that there was a lot of overlap during those first 6 months when COVID became a big deal, first in China, then Europe, and then in the United States.
Understandable. So you have been on the front lines of anti-misinformation in the past, and you just saw an opportunity to combat that a second time.
Exactly. And it's kind of ironic, Alicia. Originally, I was sending it out to just physicians in my medical center. And typically it would be cut and paste on an email of like a New York Times article or a Seattle Times or Washington Post article, and just saying, hey, this is what's going on now, blah, blah, blah. And I started, my son said, Dad, my friends want to read this, but no one reads the emails. Why don't you start a blog? And at the time it was like, what's a blog? But I have a younger son who is into digital arts and has a degree in digital arts. And so between my older son encouragement and my younger son's willingness to help, started doing it as a blog. And in that context, started sending it, once it became a blog, not just for people in my medical center, physicians, but really for patients, and particularly with a focus on general information, but subset information for COVID and cancer and COVID and HIV.
Excellent. And so if you could provide some insight, so how do you feel COVID has affected cancer care?
Wow, there's been so much written about it, and, the research is just coming out, but I think in the beginning, I think all of us were a bit shocked, like, where are our patients? What's going on? Mm-hmm. And, the New York Times referred to it as this eerie silence in emergency rooms. Like, how come no one is having heart attacks during the early days of COVID? And of course, we realized that people were having their heart attacks and their strokes just as frequently, but they weren't coming to the emergency room. Mm-hmm. And in fact, when we talk about 700,000 deaths from COVID in the United States now, we really understand it's probably quite a bit more than that. And a lot of people died either directly from COVID and the fear of coming to emergency rooms, or died from strokes that could have been prevented or could have been treated, but didn't come quickly enough to the emergency room. So the spillover effect came with our cancer patients too, as they became reluctant to come into clinic. And it also was compounded by our own concerns about immunosuppressing those patients, not knowing what the effect of our treatments might have on their risk of COVID. And of course, there were a huge number of patients who I don't see in the front end, but I see in the back end, women who weren't getting their mammograms, men and women who weren't getting their colonoscopies, people who weren't coming in for their well physical exams where cancer is sometimes picked up. So it had all of these kind of downstream effects. And so that was one huge area which affected us enormously. And then just as we're communicating right now by video, that was another really big kind of transformational event in care of cancer patients and in terms of COVID, in terms of not having those patients come directly to the clinic, but when possible, do these meetings by video.
Got it. So you're kind of helping them to bridge the gap with some telehealth.
Yeah, but it, just as we've seen so many disparities magnified during COVID, and that was true during the AIDS epidemic as well. How many people don't have computers? How many people don't know how to use their computers? Who are the people that we're really connecting to in these video visits? So it's heightened disparities on a lot of levels too, even though it's maybe has the potential for leveling the playing ground in certain areas as well. And Alicia, I think a really big area is that, the effect of, we're now finding, what is the effect of our chemotherapy and our immunotherapies on the COVID vaccinations themselves. And one of the things we've realized is that a lot of cancer patients who have gotten their one or two series vaccines are not necessarily protected from COVID. And, that's where the whole push with boosters became really important. So there are so many levels. It's almost like this huge pie of from people not wanting to come in for fear of getting COVID, people not coming to the emergency room, people not getting their cancer screening, and then even how we connect with them by video. What are the pluses and the minuses of that? And followed through to what are the effects of our treatment? And we've done it both ways. We've tried to limit treatments during COVID, and that's had a boomerang effect. So many things that we have good intentions with COVID, but they kind of boomerang on it. And many people delayed their treatments, thinking that it was too dangerous to receive treatment. And now we see that there were many adverse outcomes in people who really did need to get their treatments, but because they or we delayed their treatments for fear of COVID, caused new problems.
So many things come down to access. Do you have any kind of tips for us as we see our patients daily to help them access care and to encourage them to come in today's environment?
Yeah, I think,
what has worked for you?
Yeah, I think we had gotten through a big hump until the last surge with Delta, meaning that people were just getting comfortable coming back to clinic. There was a heightened awareness about the negative repercussions of missing visits, missing routine care. And then we kind of fell smack dab into it again with COVID, Delta variant, which was much more transmissible, much more, problematic in terms of preventing people from getting it. And so we kind of had to do the same thing all over again. And it's been really, I'm thinking about my life in the clinic, but also my life upstairs with our patients there. Leukemia patient typically will spend a month in the hospital getting induction chemotherapy, and the devastation of not allowing family members to come in freely. And another really big issue. We had developed infection protocols, and we made sure our the visitors were, properly screened and cleared. But with the Delta variant, we had to kind of stop all over again. And for a while there, we eliminated all visitors from the medical center. And now we kind of, depending on the surge and the numbers, we parse it out a little bit differently, but still very challenging to easily access family members who need need the patients who need their family's supports.
Absolutely. So maybe facilitating that in some other way. Right. iPads, FaceTime to provide that support.
Exactly. And those are those are, I think people are becoming increasingly used to it. But again, if you think of most of our cancer patients as being in their 60s or 70s, sometimes even older, and their facility with using an iPad or a smartphone is really limited. And our nurses do a great job of helping them through that. But it is shocking to see how many people come in without a smartphone, without an iPad. Something that we all take for granted is not as easily used. And so that still remains a huge barrier.
Exactly. Unfortunately.
Yeah.
So we were just talking so much about technology, and it has really changed how we think about treating cancer patients. So can you tell me a little bit more about how do you think artificial intelligence, AI, and genetic sequencing is shaping the future of cancer care?
Wow. So AI is a big topic and one that I probably can't give good answers to because it's not a part of my field, but it is moving forward and developing algorithms for care and developing patterns of outcomes. So really not so much artificial intelligence, but using big data to help our patients. So, when we do clinical trials, we often have, particularly I'm involved in something called the AIDS Malignancy Consortium. And our trials may have 50, at most 100 patients in a clinical trial. But if you can harness big data from real world experiences, like through insurance data and the like, suddenly you have information on millions of people at your disposal. And so learning to use that kind of data in a positive way. We know that companies are using big data for marketing, but how well we could use it to improve outcomes. So that's one big area. And I think that's showed us, gives us a lot of insight about what area codes don't get free access to care. A remarkable presentation a year or two about prostate cancer in Chicago, and Chicago has some of the toniest areas, kind of like your area in Florida. There's some really beautiful areas that are very well resourced, to say the least, but there are areas of Chicago that are devastated by poverty, and outcomes of prostate cancer in African Americans in those communities is among the worst in the world, not just in the United States.
Wow.
And so understanding where you live has a big difference in terms of how you access care. What are the economics of your situation has a huge implication too. So harnessing that kind of big data, which is a little bit different than artificial intelligence, is really, really important. Now, you also mentioned a second thing that I don't remember.
Oh, yes. So I was wondering about progress in genetic sequencing for cancer treatment.
So that is a huge area too. And so the ability to do next generation sequence testing on tumor tissue or blood samples has had a huge potential for moving our fields forward. So for example, I do leukemia and lymphomas, and we use next generation sequencing to plan the treatments that we know have the highest likelihood of working based on tumor mutation patterns. And there's a whole area right now of studying blood. It's kind of ironic because we have, I forget the name of the woman who is on trial right now for claiming that she could do 100 different tests on Elizabeth Holmes,
Yes.
So Elizabeth Holmes made claims that she could take one drop of blood and do 100 different tests, and wouldn't that be wonderful? And of course
it would be.
It would be, but it was a shell game.
Yeah.
But there are a lot of efforts right now to take a sample of blood and look for tumor sequences within the blood, DNA codes or complementary DNA. And that allows us the potential for diagnosing or identifying recurrence of cancer months before it might show on an X-ray. And so that's really powerful technology too. So I don't do a lot of hematologic cancers like breast or lung or colon. But those are all standard now for those kind of cancers to do next generation sequence testing. And it provides huge insights into providing non-traditional forms of chemotherapy, not the typical cytotoxic chemo that causes hair loss and nausea and vomiting, but typically targeted therapies that have much less risk of complications.
Wow, technology has, just changed the world of treatment, it sounds like, or slowly anyways, changing the world of treatment.
Slowly, but now quickly. So, I think of so many of the cancers that I treat. Lymphoma would be an example, myeloma would be another, where we treated it the same way for years. Same with colon cancer and prostate cancer. Now suddenly we have all kinds of different arcs of treatment, which are completely different. And so it's made it very dynamic and very much changing every 6 months to a year. And, we used to
that often.
Yeah.
Wow.
We used to get 1 or 2 drugs a year from the FDA that were approved for use. And now we're getting several every month, and so this field is churning very, very quickly. And it is making a big impact on people who are living with cancer.
Wow. So we've talked a lot about all the different progress that we've made, and we've also talked about the inequalities and the rising cost of care often comes up in my conversations. What do you think healthcare professionals can do to make a difference in this area, to make treatment and care more accessible?
Wow. So there are probably a lot of things. And I think that in terms of, equity and diversity, those are things that are becoming very common words to use these days. And it's going to be really important that these just don't become part of a lexicon of discussions, but rather have real bite to it. And I think that
more than just lip service, right?
Exactly. And I think that a lot of medical centers are moving in this direction. I think they've slowly begun to appreciate, or it's been called out, the inherent biases that people have and the way that we navigate patients through our clinics and what are the barriers that we put into getting care. And so those are huge issues. And, I think the other area is the price of care, which is, something we can all appreciate. And it's a catch-22. And I was involved in a situation with one of our retired physicians. So this is a woman who's worked for 35 years as a primary care provider, and she developed lung cancer. And suddenly she's looking to get an experimental a drug that had been experimental, but is just moving through its FDA approval process and is now available. That drug costs $130,000 a month.
Oh my goodness.
And, she's hanging on to that drug, but who can pay $130,000 a month for treatment? And that is really, unfortunately, incredibly common. So, how do we get our healthcare equitable? How do we get it affordable? What are we doing that's different than other countries that seem to get it a little bit better?
Yeah.
Particularly since there are enough metrics to say that even though we have availability of cutting edge treatments, the general health of our populations are not as good as other countries, And so, again, very top heavy in terms of high technology, but very low emphasis on getting patients equal care, getting insurance plans that really cover the things that they need, breaking down prejudices on both sides about what medicine's about and what it can do.
So maybe just discussions as a group to change the process.
I think that partnering with politicians too, I think are really going to be important. And again, I think this is the right time. It's kind of like the Me Too movement. It took a certain process to occur where people could band around it. And ironically, some of the good that's come out of COVID is kind of showing us how poorly we do many aspects of medical care. And hey, maybe this is an opportunity and time to do things a little bit better, reimagine how we develop those processes.
Okay, that makes sense. So now that we see it on the news, there's no escaping the inequity of our healthcare system, because we see the numbers all the time.
Right. And we look at who's been most affected by COVID. It's been people of color, people of low socioeconomic status. Mm-hmm. It's people who live concentrated together. And of course, now we're seeing another level of misinformation, people who won't get vaccinated or refuse to be vaccinated or are not willing to get vaccinated right now. And 90% of our inpatients are filled with people who have not yet gotten their COVID vaccine. So again, that level of misinformation, of mistrust that's going on is really profound right now.
Unfortunately. So your blog is so full of insights on COVID, but I know that healthcare professionals are usually really hesitant about putting their views on the web. I know that from my guests and also from my audience. So they're afraid to put their views out. They don't want to be, misconstrued as representing the health system that they work for. Do you have any tips for other healthcare professionals who, like you, they want to express their views online, but they want to do it in kind of a safe way? What do you recommend?
Yeah, I think at first it is a challenge. And, I feel like I'm not so I think that certain mediums can grow very quickly, like YouTube and Twitter. And if you develop a huge population or a huge following, inevitably you're going to offend some groups, or it's very hard not to. And I think that the best you can do is be careful not to speak inflammatory, use inflammatory terms. And if you do have frustrations, not to show them in that way. I think it's no different than when you're a physician and you can be really frustrated with your patient. I told you not to smoke, or I told you needed this test, and that kind of browbeating gets nowhere.
Might not be the most effective approach.
Exactly. But, I think physicians in general now are getting pressured to either provide scripts for things they may not believe in, and parasite, drugs that are used as antiparasitics for animals. Or medical disabilities or medical exceptions for people who don't want to get vaccines. And again, that puts us in a very uncomfortable way. And I think the same way that you would navigate those very carefully and deliberately, focusing on education and trying to be consistent, is helpful when you're communicating as well. You also have to realize that you're not going to be able to convince everyone. And I don't necessarily go into trying to convince people of certain opinions. It's merely, providing information that I think is accurate and explaining why certain medications may not work, why others are more useful. In that context, it's no different than when we talk to a cancer patient and we're talking about a whole suite of different treatment options, whether it's a recreational drug that helps them cope with their anxiety or their depression or their pain with their medication, or whether it's choosing the best treatment, And so it is a challenging time. I think that many people have been able to promulgate views that are not based on reality, and there's still enough data out there that says that physicians and people in healthcare, like nurses, are still very well respected and that people will listen to them. That said, if you have someone who's anti-vaccine and gets their information from an alternative source than a reputable medical one, you have to realize that you can only provide the information. But if you start getting into a debate or trying to fight it out or duke it out, it's not going to work. I've seen many columns or forums for people who are trying to get into social media. These are the things you want to do. These are the things you don't want to do. And you don't want to put too much personal information and personal opinion out there unless it's backed by science. And so I think that's a really key thing as well.
Excellent. So maybe bring some of your your bedside manner into the social media or the blogging space. Exactly. And make sure whatever opinions you have are based on fact and not just opinions.
Exactly. And provide references, people who do Twitter, it makes sense for them to say, hey, there's this really great article in the New England Journal, check this out. This is why it's important, that kind of stuff is really useful. Or if there's an important announcement that's coming up, hey, the CDC just emphasized today that we should be getting flu shots along with COVID boosters. That's important information, and that help gets that information out there too. And so I think there's like this really important space of getting really important information out, but hopefully not in a way that alienates people that you're trying to reach as well.
Okay. So that seems like a relatively safe place to start, right? Exactly. To take established, trusted sources and just amplify on Twitter or Facebook or whatever your preferred platform would be.
Exactly. And if there is something that's controversial, say, hey, this is why it's controversial. And this is, these are some of the reasons to support this notion that it may be helpful in this context. Mm-hmm. And, I think one of the things I saw, though, I thought was really interesting, someone was talking about why he didn't trust the CDC, Mm-hmm. And, he made the point that, if the CDC had been more transparent early in COVID and admitted the things that they weren't sure of, rather than pronounce things as facts, that might have made a big difference, I think we all appreciate now that our trusted sources can be politicized as well. And so I don't think it's unreasonable to be skeptical. I think some level of skepticism is good, but not to the point where it's to distraction and to discount useful information coming from a variety of different and trusted sources.
Understandable. It's a really good point. So you have done so much incredible work with medical aid overseas, particularly in India with the Binaytara Foundation Cancer Center.
Yes.
And just this year, you won an award for your leadership there. Congratulations.
Thank you.
Can you tell us more about that organization and how you got involved and maybe how our audience could help?
I would be happy to. And so this is one of the few areas where I think there's unambiguous good. So what by that is that every medical center is asking for money. Every medical center is asking for donations. And, a lot of times we get jaundice that's going to a new building that has, really pretty paintings on the inside. But how does it really help our patients? And the Benetara Foundation is a foundation that was created by Binay and Tara Shah, who are from Nepal. And Binay is a medical oncologist who works here in the Seattle area. His wife Tara is a nurse, and they wanted to give back to their community, which is in Janakpur, Nepal. And they've been working to create cancer care in an area that largely has none. And I think it was back in March of 2020, really right before COVID was kind of hitting, or maybe it was February, before COVID was hitting here, but it was pretty clear this had ravaged, Wuhan, China. There was no way it was going to be controlled. And I went with Binay and Tara to Janakpur, Nepal, and looked at the work they did, and I was just so blown away with it. And so they've devoted their life to this mission of creating a cancer center in Nepal. And I think it's like one of these areas where it's only good. There's no, I don't mean this glibly, there's no corruption, there's no misspending of monies. They're both remarkable people. And with a foundation that started with 2 people, just them, they're building a cancer center. And wow. They are doing amazing work. They are devoted to looking at healthcare disparities across the board in cancer care. And Binay has been sponsoring a meeting on Cancer Care Disparities for now several years that meets here in Seattle, and we'll be having another one this coming March, so 2022, God willing, and assuming COVID is not remains the problem that it is. But it was an easy thing for me to get into, and what's been just amazing is that so many people are getting into it also and devoting their time and their passion. There are oncologists from all over the world that are participating in this effort. And Binay and Tara are not content to just build a hospital in Janakpur. They created a journal looking at healthcare disparities in cancer care. The maiden issue was just released, and that is going to be something. And they also do continuing medical education, or CME credits, and they're among the very biggest. So we have ASCO, and we have ASH, and we have many other ways to get our CME credits, but Binay is kind of redoing that whole effort. And with cancer care, so we had ASCO updates, we had American Society of Hematology updates. As I said, the Cancer Care Disparities Conference is the biggest in the US, and it has luminaries who've been in this field for decades, not just the last year or two, in that too. So when I went there, it was like, I don't really believe these guys, and I don't think I can imagine just a couple doing so much work. And then when I got there, I was completely blown away. And now I've seen as it's grown from like a seed of an idea to this really powerful grassroots group with so many people working on it. So that's been a pretty amazing experience for me.
And that was the Cancer Care Disparities Conference?
Yes.
Wow.
Yeah. And we had one, they've had one for the last 5 years, I think. Unfortunately, the one in March of 2021 had to be canceled because of COVID.
Understandable.
But, we'll have one on March of 2022, and that'll be on YouTube for those who can't travel to see.
Oh, that sounds like a very valuable event. Don't want to miss it.
Yes, that'll be something for everyone for sure.
Yes. If our viewers would like to get involved and help the Benetara Foundation, how can they do so?
I think the easiest thing would be to simply Google Binaytara, Binaytara, one word, Binaytara Foundation.
Okay.
And then they can go to their website. They have, I think, on the website a video also, which is really quite incredible. Binay, who's a very persuasive person, had one of his nurses from Bellingham, Washington, volunteer some time in Janakpur. And her son was in high school and came along, and he created a video which is just unbelievable, describing the vision and the work and the efforts that they're doing. It's definitely useful, and that's it. Someone can find that on YouTube as well, but I bet you it's on the BTF website, and it can give a lot of information about the educational initiatives they're doing, the work they're doing in Janakpur, Nepal, as well as the work here in the United States.
Wonderful. What I can do is I can put a link to that video in our show notes.
Oh, that would be
so
awesome.
That all of our listeners and viewers will be able to find that so very easily.
That would be great.
Wonderful. So as we wrap up, are there any words of wisdom or inspiration that you'd like to share with our audience?
Ooh, that's a toughie. So a couple of things. I mean, my gosh, we're still in the middle of COVID, and we're moving well into our year number 3 soon of this whole thing, and just incredible. But I think I would be optimistic about a few things. I think that telehealth is here and hopefully here to stay. And as we look to bridge, gaps with how people access care, and think about people in rural areas, people who can't travel easily in cities, people who are bedbound or housebound. What a great thing to have telehealth available. And hopefully this will become something that we don't let go of once COVID is in the rearview mirror. but it becomes something that we utilize. And then I think that, for our patients' care, we really need to stay vigilant, particularly in the field of oncology, where so much is being learned about how our treatments impact immunizations and schedules of immunizations. What are the implications for delaying treatment that's necessary? What are the barriers that we have in place now? Which could it be improved? Are all things that are kind of like on the forefront of cutting edge care now that were not there 2 years ago. So I think that'd be something I'd be really super encouraged about. And, technology doesn't solve all of our problems. And so there's going to be a lot of human effort too, but it is encouraging to see new forms of technology being leveraged at a time when we really need it.
So there is some hope.
Absolutely.
Dr. Aboulafia, this has been a really great conversation. For any of our listeners who want to reach out with a follow-up question or just want to reach out to you, what's the best way for them to do that?
I think they could email me. That's probably the easiest.
Okay. I can put a link in our show notes.
That would be great. And then if anyone's interested in looking at the COVID Cogitations, usually I'll put it out once a month, and it'll be pretty much a summary of the month's events, but it's general and it's educational, but it's not meant to be preachy. There will be areas where there's strong opinions given, but it's counterbalanced by the articles that it's referencing. And there's kind of a wide variety of stuff for cancer, for HIV, and for just general information.
Absolutely. I'm a subscriber to your blog, and it is very approachable, and I appreciate it.
Well, thank you so much, Alicia. And it's been great to talk to you and connect in this way. And I'll be looking forward to watching your program from now on as well.
Awesome. Thank you again for your insights. We really appreciate you being a guest.
Thanks for inviting me, Alicia, and all the best to your viewers as well.
Thank you.
You've been listening to Working in Oncology. To ensure that you never miss an episode, subscribe to the show in your favorite podcast player. If you're listening in Apple Podcasts, we'd love for you to leave a quick rating of the show. Just tap the number of stars you think the podcast deserves. Thank you so much for listening. Until next time.